Hi, everyone. So again, I'm Poonam Hosamani. I'm one of the hospitalists here. So when I first started at Stanford, I was asked to do a Stanford 25 session on the knee exam, which is really not the most glamorous of exams. I don't get cool gadgets or anything like that. But I thought, I'm going to own this. I'm going to make it my own. And so when I did my session, what I did, and this is a nice technique that some of you could use, is I started off by showing some videos of sports injuries, because who doesn't, cringe at a good sports injury, quarterback getting tackled and throwing his knee out. So that was a good way to get everyone excited about the knee exam. And then I also relate it back to my own story, which if you guys remember to Errol's presentation earlier, he showed you a picture of me examining my husband. So I first started doing the knee exam a little more rigorously after my husband came back from a wedding and came back with pretty severe knee swelling. And this is why my husband is not allowed to go to weddings unsupervised anymore. But he was basically a result of overly aggressive dancing. And so we did the knee exam on our living room floor, and I was able to diagnose him with an ACL injury at that point. He has since gotten it repaired, which is why we have Vijay Prabhakar, one of our wonderful interns, to sub in as our patient, because my husband no longer has findings. Vijay, by the way, is a future cardiologist for any of you who are looking for fellows, so keep him in mind. And the other part of the knee exam that I really love is that it's a very elegant exam, uses no equipment besides just your own technique. And you can really diagnose quite a bit just by using a few different maneuvers. So this is by no means exhaustive. This is by no means meant to replace what an orthopedic surgeon might do, but really just to give our residents, our learners, some quick tips, things that they can do with their patients to diagnose a pretty serious knee injury versus maybe something that's a little more mild. So Vijay, what I'll have you do first is if you'd stand up for us. Always start off with a visual inspection, just as Neil went through, looking at just the basic anatomy of the knee. If I could have you just pull up your shorts just a little bit, perfect. So looking at any asymmetry that you might see between the knees, any differences in color, any changes in the dimpling pattern between the two knees that might indicate an effusion. You can also look for alignment of the hips as well as the ankles, knowing that pain can obviously be referred from either of those two joints. Everything looks pretty normal here for the most part. You can also look for things like muscle bulk and things like that, or atrophy that have happened over time. Let's go ahead and lay down for us. And so we'll move on to the palpation portion of the exam. So Vijay actually has a left knee injury, but just for the purposes of demonstration, I'll show you most of the things on his right. But for palpation, one of the big things that we look for is obviously for differences in temperature, and this is really useful for a variety of clinical settings. On the inpatient side, when we see patients with a concern for a septic joint, differences in temperature are really notable, can make a lot of difference in whether we decide to tap a knee effusion or not. So I was using the back of the hand, testing the difference between the two. A lot of people also sometimes will just put their hands on both knees and then switch them to see if there's a noticeable temperature difference between the two. In terms of looking for an effusion, sometimes more subtle effusions can be really hard to delineate just by visual inspection. And so what we can do at that point is a couple of different things. Some of you may have heard of something called ballottement, or looking at ballottement of the patella. And this is when you try to milk an effusion that might be superior. If you want to zoom in a little bit here. You can milk an effusion superiorly, so it comes down into that patellar space, and then look for any buoyancy there. It's actually not too much. And we can do the same thing here as well. There's a little bit there. It's maybe very, very mild effusion at best. So that's really for the palpation portion. Now we get to, I'll skip range of motion because that's something that a lot of people feel pretty comfortable with, and get into our maneuvers, which are really the trickiest part. So one of the first maneuvers that I do is looking for any ligament laxity, so particularly ACL or a PCL injury. So the anterior drawer is one of the easiest tests to do, and we have our patient flex to about 90 degrees, and we usually have to stabilize the foot at this point to really get a good sense of whether or not there's any joint laxity. So you just stabilize by sitting on them very gently. Put your thumbs on either side of the tibial tuberosity and give a quick, gentle pull forward. And we see that Vijay doesn't really have any joint laxity at all. He has a pretty hard end point. There's no movement of the tibia forward when I pull. As a corollary, though, actually, if you can move just a little bit this way, we can angle it. So this is actually his affected knee. Just flex a little bit more here. Actually is, I don't know if anyone notices that, but there is a little bit, I can actually feel that there's not as hard of an endpoint there, and that the tibia is actually displaced anteriorly as I pull forward. As a corollary as well for the PCL, you can do the posterior drawer, which is where we do the same thing, but just push. And we see that there's no posterior displacement of the tibia. There's also something called the sag sign, which is just more of a visual inspection test where you can have the patient flex both of their knees and look for any posterior displacement. Gravity will certainly help you in this case. You'll see posterior displacement of the tibia in relation to the patella along that line. You can see this visual line here. You'll see posterior displacement if there is a PCL injury. So moving on with our ligamentous injuries, the next would be looking for MCL or LCL, or medial or lateral collateral ligament injuries. So the easiest way that I found to do this is actually to stand kind of at the foot of the bed or the examining table. You want to have the patient flex to about 30 degrees. This amount of flexion will actually help to avoid any recruitment of any other structures that might stabilize the knee, as opposed to having them be in full extension. So just a little bit of flexion. And you stabilize the ankle, and you can apply varus and valgus stress to see if there's any movement of that joint in one way or the other. Increased laxity would indicate that there is possibly an injury in one of those ligaments. So we've already gone through ACL, PCL, MCL, and LCL. And then the last is to look for any sort of meniscus injury. And this is the dreaded McMurray's test that everyone tends to have trouble with because it is quite complicated. But having looked through quite a few resources, the easiest way that I found is to have the patient flex both their hip as well as their knee about 90 degrees. And you want to place your hand along the joint line here so that you're right along where the meniscus, the bilateral menisci are, and then have them evert and apply valgus force, so force coming from lateral towards the medial aspect, and then have them extend. And what you're looking for is you're palpating for any sort of a click or a pop that might indicate that there's an injury. You want to do the corollary for the other side, invert the foot, and then apply varus force and do the same. Extend. And so Vijay, again, this is his affected leg, actually does have a click that I can feel on exam, which would indicate that he likely has an injury, an old injury, because he doesn't really have any active joint swelling. Right. All right, so that was actually very quick, as you can see. I mean, this is something that we were able to do in 5 minutes very quickly to just get a good sense of if there's any injuries, anything that we need to be aware of. Vijay, you can sit up for us. Do you mind telling us what your injury is?
So I have a complete ACL tear, complete maceration tear of medial and lateral menisci.
Yeah, for those of you who didn't hear, so he has a complete ACL, unfortunately. And one more time.
Oh, yeah, and medial, lateral menisci, I think the posterior horns both have complete tears as well.
So we'll be using Vijay as our patient for quite a while until he gets that fixed.
Were you dancing? It was from basketball.
It's a more legitimate injury answer. Great, thank you so much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.